Hi, my name is Tanya Lalatortu, and I am a resident at the University of Florida Internal Medicine Resi program, and I'm presenting a case of hepatitis C associated cryoglobulinic vasculitis. Cryoglobulinic vasculitis, also known as CryoVas, is a small vessel vasculitis associated with the presence of circulating cryoglobulins. Treatment depends on the underlying associated condition. This is a case of hepatitis C associated CryoVas. This is a case about a 41-year-old woman with a pathological history of IV drug use that presented in 524 with several painful cutaneous lesions on her leg. Lesions started in 324 and she had received extensive infective workup on an outside hospital. She had a biopsy of a right thigh lesion that was consistent with a wound. She was negative for Coxiella Bertinel, Rocky Mountain spotted fever, typhus, and HIV. She had Burkholderia cepaciae detected on blood culture and Bartonella on serology. She was diagnosed with eczema granulosum and discharged on trimethoprim sulfamethoxazole, which did not resolve her lesions. She presented for a left thigh lesion that was rapidly expanding. CT of her thigh showed superficial soft tissue edema. She received a biopsy of a left thigh lesion that showed thrombotic vasculitis involving small and medium-sized vessels. A CTA of her chest, abdomen, and pelvis showed no evidence of further vasculitis. Her lupus anticoagulant, blood cultures, and TB tests were all negative. Her C3, C4, and rheumatoid factor levels were all normal. Hepatitis C antibody was positive, and her viral titer was over 6 million. She had no known history of hepatitis C. Her first cryoglobulin lab was negative, but the second one was positive. The cryoglobulin was characterized as a type 3 with polyclonal IgG and IgM. She was given a dose of 500 milligrams of IV methylprednisolone, but was stopped because of concern for endocarditis, so she had initial improvement in her lesions on the steroid. She had a TTE that was negative for vegetations and a TEE that showed a mitral valve vegetation. She left against medical advice, ciprofloxacin and doxycycline for subacute endocarditis due to Burkholderia cepaciae versus Bartonella due to previous positive labs. She followed up with dermatology outpatient a month later with worsening ulcers on her leg. She was started on an 8-week course of prednisone and referred to gastroenterology for hepatitis treatment and was started on sofosbuvir velpatasvir. She followed up in a month with dermatology and endorsed no new lesions and improvement in her ulcers. Image 1 shows her left thigh lesion status post-biopsy. Image 2 shows her right thigh lesion. Image 3 shows her right inner ankle lesion. And image 4 shows her right outer ankle lesion. This patient had prior extensive workup for cutaneous lesions that was only significant for positive Burkholderia and Bartonella that was treated with trimethoprim sulfamethoxazole with no improvement. Upon hospital discharge, 2 plausible causes of her vasculitis were hepatitis C, CryoVas, and subacute endocarditis. Given that she had worsening cutaneous ulcers on antibiotics for endocarditis, her ulcers were attributed to hepatitis C, CryoVas, and her diagnosis was reaffirmed after she improved after being on antiviral and steroid course. This case highlights the importance of retesting for cryoglobulins as they can be falsely negative due to improper handling and processing errors. There are 3 types of CryoVas. This patient was a type 3 CryoVas, also known as mixed cryoglobulinemia. It is characterized by polyclonal IgG and IgM and is strongly associated with HCV infection.